In this video, we will briefly describe the concepts of spinal and epidural analgesia. Opioid agents may be administered by multiple routes, and they may be administered systemically and locally. It is also important for us to know that opioids may also be introduced into the epidural space and into the intrathecal spaces. When we administer opioids in this manner, it allows a large area of the body to be rendered pain-free. Sometimes opioids may be introduced into these spaces in combination with other drugs, most notably local anesthetic agents. When opioids are administered spinally or epidurally together with local anesthetic agents, these opioids can exert direct analgesic effect on the spinal cord and the nerve roots, and they can also prolong the duration of sensory and or motor blockade by the co-administered local anesthetic agents. The co-administration of opioids in such a manner will permit the use of lower doses of local anesthetic agents, and this approach is commonly employed in regional anesthesia, which is a viable alternative in certain cases to general anesthesia. We need to note at this point that the most widely used hydrophilic opioid in spinal anesthesia is preservative-free morphine. It is commonly employed together with local anesthetic agents to provide regional anesthesia in procedures such as cesarean deliveries, hip or knee replacement surgeries, and various abdominal surgeries as well. Okay, so what exactly are the spaces into which opioids are introduced when administered spinally or epidurally? So let us assume that this is a cut section of the spinal cord, and what we are looking at here is the anterior or the front of the patient, and here is the posterior or back of the patient. We are looking at the central canal in blue. That is the spinal cord in gray. The spinal cord is wrapped up in a layer of meninges, and this is called the pia mater. Now, posterior to that, we find the ligamentum flavum, and in between the pia mater and the ligamentum flavum, we get the dura mater. The space between the dura and the ligamentum flavum is what we call the epidural space. And now, in between the dura and the pia mater, we get the arachnoid layer of the meninges. And the space between the pia and the arachnoid is what we call the subarachnoid or intrathecal space when viewed from the posterior aspect of the patient. In spinal analgesia, the drug is injected into the subarachnoid or intrathecal space, while in epidural analgesia, the drug is injected into the epidural space. Subarachnoid or intrathecal space contains CSF. The epidural space does not contain any CSF. Spinally administered opioids by themselves may not provide satisfactory anesthesia for surgical procedures. However, when used with local anesthetic agents, spinal or epidural opioids can provide excellent analgesia following surgery. This produces less adverse effects than those produced by systemically administered opioids. Repeated doses of epidural opioids without local anesthetic agents can provide good analgesia in terminally ill cancer patients. Now, there are two important complications of spinal and epidural analgesia, and these include post-dural puncture headache and shivering. Now, regarding post-dural puncture headache, the characteristic feature of this phenomenon is a headache that is relieved by lying supine. Conservative management for post-dural puncture headache include supine positioning, hydration, oral analgesics, and caffeine. The definitive treatment of post-dural puncture headache, however, includes the administration of epidural blood patch. In the case of shivering, this can occur when local anesthetic agents are also introduced into the spinal and epidural spaces, and the rate of shivering may be as frequent as up to 55%. The intensity of shivering is likely more related to epidural anesthesia than spinal, and the addition of meperidine reduces the likelihood of shivering.